our expert electrophysiologists in ultrasound. We have Chris Fox from UCI. He is Assistant Dean of Student Affairs. He's also a professor at UCI, world-renowned speaker. We're very pleased to have him. So please welcome him and get ready to learn some awesome diastology and EBM ultrasound. All right?
Thank you very much. Thank you. Guys, it's an honor to be down here. I've never been to this facility, and it's beautiful. We took a little tour earlier, and it's massive. I mean, you guys have, I think at UCI we have 30 beds right now, and you guys are over double that, so compared to us. So it's a big shop down here. My medical students keep coming down here, and they love it, and so now I know why. It's a great location too. It's kind of in this spot up here, and in the center of everything fun to do in San Diego. So I can see why you guys like working here. So I'm going to there's a lot of stuff, so I'm going to start and just go, all right? And feel free to stop me. This will be very interactive. I don't understand that. What are you talking about? Back it up. I know there's different levels here. I wasn't sure at what level I should to kind of put this, but I figured it's always good to start out. I know they said there'd be no math involved when you got to work today, but I think it's good to start out with with the Doppler equation, just to kind of immediately make your eyes glaze over and forget everything I'm about to say. And really, actually, the only thing you got to know is well, this arrow should be over here. This cosine of theta, actually. Cosine of theta, as I'm sure you guys already know, is in the numerator of the Doppler equation. And that's really, really important because this helps you understand a lot of the stuff we're about to talk about and why we get certain windows when we're working with particularly with the heart. So I don't really use a lot of Doppler for stuff. I might use a little Doppler on the nads, on the gonads, when I'm worried about lack of flow or maybe hyperemic flow, both males and females. And maybe I use a little Doppler sometimes when I'm looking at some of the neck vasculature, if I'm doing something up there. But for the most part, I use Dopplers with the heart. That's really where it comes into play for me, and not in a lot of other ways. And the reason why we get these windows is because of this cosine of theta. You see, when you're working with B-mode ultrasound, just as a quick review here, B-mode ultrasound, straight up 1972, white dots on a black background, you want to be perpendicular. The more perpendicular you are, the better. But when you work with Doppler, it's the opposite, actually. You want to be more parallel. And so it's the whole reason why the cops down the road can get you with the radar. They get you way down the road when you're more parallel to them. But it's like, when my wife's driving along, and all of a sudden she looks over to her right, and she sees a cop on the side of the road, she jams on the brakes, and I'm like, Danielle, now come on, cosine of theta is in the numerator of the Doppler equation. Why would you hit the brakes when you're perpendicular to the cop? He got you way back up the road. So that's. I just want you to remember that, because this is the apical four-chamber view here on the screen. And this apical four-chamber view, this is the best window to check for the valves, the color flow in the valves, and also the pulse wave Doppler and the tissue Doppler, because things are moving very parallel to where the probe is. Because if you look here at the top of the screen there, this is where the probe is. That's where the sound is coming out of. It's in the apical window of the body, and the blood flow is very parallel. The red blood cells move up and down in a very parallel fashion, as opposed to like the peristernal long axis. You think about the valves in the peristernal long axis, like the mitral valve, and the flow is very perpendicular there, and so it's like changing from red to blue, and it's not as accurate in that window. That's why we use that view. And by the way, the apical four-chamber view, it's the most difficult window to get of all the cardiac windows, okay? But it has the most information, though. And so I love this view. I've sort of become obsessed with it over the last few years. I don't know if you guys listen to the Ultrasound podcast, but Mike and Matt, those guys are amazing. I listen to their podcasts, and I've learned so much over the last few years. And I'm going to try to bring some of that to you right now. But the apical four-chamber view, I tell that patient right there to roll into a car model position. And see, that's kind of like what he's doing. He's laying across that Corvette, like modeling it, And it's funny how you can try to describe the position, or just say roll into a car model position, and like 80% of the time, people are like, oh, okay, like this. Like they know immediately what to do, because that's an important position, because it brings the apex of the heart right to the chest wall, and you get that PMI right underneath the nipple, the point of maximal impulse, the dime-sized area on the chest wall, where the heart actually comes right to the chest wall. It's a tiny little spot. It's hard to find, but when you find it, it's a lot of information coming at you. So Roll the patient on their side. Putting the arm up helps open up the ribs a little, I think, and you get back to here. And this is where collar flow can be helpful. This is an example of mitral valve regurgitation. There's this thing called BART, blue away, red towards. And during the diastole and systole of the heart, B-A-R-T, blue away, red towards. And so what we're seeing here is during diastole, we're seeing that red jet come up into the left ventricle. But then during systole, unfortunately for this patient, we're seeing a blue jet back wall that left atrium. Do you guys see that? And so this is mitral valve regurgitation. It's severe, and that's about all I can tell you. I'm not a cardiologist, I'm not expert enough to tell you what grade of MR this is, but it could really help explain the patient's symptoms if you saw this back walling, either in that left atrium or in this case, in the right atrium with tricuspid valve regurgitation. You see that blue jet coming back down during systole, and that's what tricuspid valve regurgitation looks like. Here's a couple cases of mitral valve regurgitation where you see those blue jets coming back here. Here's a blue jet here. Now these are videos that didn't play, and everything seems to be frozen. And thank you very much. That concludes my talk.
We want jokes.
Yeah, more jokes. The joke is this isn't funny. This is something froze up on me here. Sometimes you just wait. You just wait.
No Mac down talk. It's not a good Mac down talk. Most of the room is on Mac.
It reminds me of a cartoon we have at UCI. It's like it's in the forest and there's this cake sitting out and no one's around it, but you see these two anteaters on each side of the cake and they're just staring at it and they say, "Now we wait." That's what's happening. So, okay, I'm gonna hit escape. That worked. Okay. Oh, maybe I'm back in business here. Let's see. Play. Oh, now we're going again. Phew. Okay, so that's the apical fifth chamber. So you're in the apical 4, and then you just tilt the probe down a little bit anteriorly. The right side of the heart kind of goes out of the way because you're looking more anteriorly, but you see the air quotes fifth chamber. The fifth chamber being that aortic outflow tract right here, and we can actually see during systole, there's a nice blue jet, right? Blue goes away from the probe, red comes towards the probe. So during systole, there's a nice blue jet, but during diastole, there's a red jet. See that little red jet that comes up? And we're kind of going through the video, we're fanning through. What's happening is the patient's breathing in and out. We're not moving the probe. As the patient's breathing in and out, it goes in and out of the view, but you'll see that red jet during diastole come into view there. And that's what aortic regurgitation looks like. Cool? All right. Until this show made the RV famous, the RV was really ignored. And I'm not talking about breaking valve, I'm talking about the heart, the right ventricle. And if you look at the right ventricle, it's got a very strange shape to it. And it's got thinner walls, and when it contracts in this cylindrical way. The LV is much simpler the way it operates. The RV is weird and complicated and has this cylindrical up and down longitudinal contractility to it. And sometimes we always think about the right ventricle being strained out in the setting of a pulmonary embolism, right? And one of the questions I have, especially when I look at that image over to your left, is that RV looks so big there. And when you've got a big blood clot in the lung, massive pulmonary embolism with cardiovascular collapse, you get RV strain, the RV gets bigger and bigger. Normally the RV should be about 2/3 the size of the LV, and here you can see that RV is huge. Usually the RV should be a lot smaller like it is over there on the right-hand side. That's a normal sized RV. Now, sometimes when you hit the cardiac mode, the dot flips to the other side, or you forget to flip the probe, and it's easy to mix up the right and left sides of the heart just by moving the probe the wrong direction or with the software changes and the dot flipping all around on you. And so there's this structure right here I want to point out. Do you guys see this thing right here? Do you know what that is?
Moderator?
Yeah, the moderator band, exactly. That moderator band has to do with the electrical system in the heart. It doesn't exist on the left side. It's only on the right side. So that confirms that I'm looking at actually RV strain here. If I was at all confused by which way my dot was going, it doesn't matter. That's the right ventricle. That thing's huge. The other way I know, this is another orientation of the heart here. Remember that apical fifth chamber I told you about? This is the aortic valve here, and it has that configuration where the blood is being squeezed right down the aortic outflow tract. That to me is that also orients me to the heart, is what I'm saying here. that must be the left ventricle, that I do not have either my dot flip or my probe reversed. Does that make sense? So moderator band and then the aortic outflow tract. So with that in mind, I want to talk to you about TAPSE, which is the tricuspid annual. It's not annual, it's annular. That's a typo. It's funny. Every time I give this talk, I laugh about the typo. But anyways, I think I would just fix it. I should just fix it right now. So TAPSE, tricuspid annular plane of systolic excursion. It's pretty easy to do. You drop an M mode across that lateral free wall of the RV. And the nice thing about TAPSE is that it's easy to do. As long as you can get that apical four-chamber view, which, as I said, is probably the most trickiest view of the heart to get. But if you can get the apical four-chamber, you can get a ton of information here by assessing the systolic function of the right ventricle. So if the TAPSE value is less than 17, you have RV dysfunction. And that's a pretty juicy piece of information to have about your patient that you can share with your consultants, and it makes you sound like you know what you're talking about. And this TAPSE, while it's simple to do, it's got really good correlation with other more complicated things like radionuclide studies and fractional shortening and all this other interesting yet way more complex stuff to do that maybe is outside of the realm of point-of-care ultrasound. TAPSE, very POCUS friendly here. Very easy to do as long as you can pull up that RV. Now, remember I told you that the RV sort of has a cylindrical contraction to it. It's sort of going up and down in this sort of pattern. And what we're looking at is that lateral free wall here, the RV. You can see it right here. This is the annual plane of systolic excursion. You guys see it going up and down? I'm trying to chase with my mouse there. See that? So if you put an M mode spike right over that lateral wall, you're going to see the M mode tracing going up and down. And if you measure that M mode tracing, it should be, well, the average is about 24, 22. If it's less than 17, if the distance from the trough to the peak is less than 17, this distance right here, if that's less than 17, then the patient has RV dysfunction. Does that make sense? Okay, cool. So these are the kind of things that you would think about in the setting of RV dysfunction, and you guys know all this medicine. It's like sepsis with endotoxins and all these interleukins running around causing endothelial dysfunction, with capillary leak, hypoxic pulmonary vasoconstriction, right-sided MIs, pulmonary embolism with RV strain, even mechanical ventilation. So that's something to think about in the setting of RV dysfunction. We're going to move on now and talk about diastology. And so we're cool with, we talked a little bit about Doppler and the flow and cosine of theta. We talked about the valvular regurgitation, and we talked about RV dysfunction. Now we're going to talk about diastolic function. And diastology really means it's the relaxation phase of the heart. And it's really, if you think about the apex of the heart and the base of the heart here, so the apex up here, we put the probe, you know, in the apical four-chamber view, the apex is up here, the base is down here. What we're about to measure is the velocity of relaxation. It's during diastole how that base relaxes away from the apex. And that's something to sort of, if you could keep that concept in mind as we go through this. Because we're working a lot here with pulse wave Doppler, we want to be in the apical four-chamber view again, a much more parallel flow of the blood. Normally, you've got the E wave and the A wave, right? The E wave is the early phase of diastole. That's when the blood is going from the left atrium through the mitral valve into the left ventricle, and you can measure that velocity using pulse wave Doppler. And then you've got the A wave, which is the atrial kick at the end of diastole. So E, the early phase of flow from LA to LV, and then A, the atrial kick with the rest of the blood going in there. And that E wave is supposed to do all the heavy lifting, and the A wave is the rest of it. And so that's why the E wave should be larger than the A wave. And you know how to do this, right? You take your pulse wave Doppler. It looks like that little TIE fighter from Star Wars. You can see it right over here. And you just put that at the tips of the mitral inflow, the mitral leaflets. So this is going to be the mitral inflow velocity during diastole using pulse wave Doppler. And you get that EA, EA, EA. Normally the E is bigger than the A, but when you start to have impaired relaxation or the beginnings of diastolic failure, then the E wave is smaller than the A wave. And that's an early part of this whole thing. So you can see here some examples here of just a normal EA pattern there on your left, and on the right you see the reversal of that where the A waves are bigger than the E waves, and that's impaired relaxation. So you could just stop right there and just go, oh, okay, I get a little piece of that. I get kind of a little understanding here. Apical four-chamber view, pulse wave Doppler, across those mitral valve inlets, mitral valve leaflets, and drop my pulse wave Doppler. And if the E is smaller than the A, then I've got some impaired relaxation, some diastolic dysfunctions going on. But if you want to take it a little further, you can actually measure how fast the heart is relaxing using tissue Doppler. Tissue Doppler measures the velocity of tissue. And so you imagine the base of the heart as it's moving away. So not with pulse wave Doppler, we're measuring the velocity of red blood cells going through the mitral valve, right? Tissue Doppler, we're measuring the tissue as it's relaxing away, as the base of the heart is moving away during diastole. We can actually measure that, and instead of calling it EA, we call it E prime A prime, because it's like going down. And if you notice, during pulse wave Doppler, we had a positive inflection, right? During tissue Doppler, we have a negative inflection because we're measuring how fast the base here descends away from the heart during the early phase in the atrial kick. Are we cool with tissue Doppler? All right? And I apologize, this is all review, and you guys are like, yeah, whatever, this is like, whatever, stuff. But I just thought it's kind of good to go through it, just to get everybody baseline.
As far as the tissue Doppler, what is like the anatomic landmark where you want to aim your Doppler beam?
Yes, I'm glad you asked that because I have it right here. Right here at the base of the septum. Right here is where I put that. So it's that right in the center. You see the lateral walls here of the heart. This is right down the middle. So for the TAPSE, we put it over here. The MO trace we put over here. For when we're doing tissue Doppler for the E prime A prime, we put the tissue Doppler sampling gate here. Some people put it over here, but I think it's easier to put it right there, actually. So then you get this E prime A prime thing, and normally E prime is greater than A prime, just like with pulse wave Doppler or the inflow velocities, but when you get the opposite of that, you get impaired relaxation. And so when you put these two things together, you've got the inflow velocities and the tissue Dopplers, right? And so in this case, this is a normal diastolic function. E prime greater than A prime, E greater than A. Now, we can kind of put all this together. This is where I'm going with this, okay? You can put all this together in this Rosetta Stone of diastology to see the level of diastolic failure. So you've got a spectrum here. You've got the normal relaxation, impaired relaxation, pseudo-normalization, and restrictive LV filling. That's where we're going, and I'm going to break it down for you guys right now on this whole spectrum. So normal the diastolic function of the heart, E greater than A. In fact, if you look at the ratio of E to A, it's greater than 1, okay? When it comes to the tissue Doppler imaging, this is the velocity of relaxation. If you take the E from the pulse wave Doppler and divide it by E prime, you get less than 15, which is normal, or just an E prime value greater than 8. When you have impaired relaxation, now your E to A ratio is less than 1. Okay, if you look at that, during impaired relaxation, the velocity of flow through that mitral valve is not as good as it was before because it's not relaxing as much. And so it's actually the atrial kick that's bigger than that inflow velocity. And then when you look at the tissue Doppler, your A prime is greater than your E prime. And so you have like a total reversal of what you would normally expect. That's impaired relaxation. But then suddenly, things are getting worse, but it almost looks better because you get this pseudo-normalization where your E is now greater than your A again. You've got that normalized ratio. E over A is greater than 1, but this is why tissue Doppler is important, because when you throw the tissue Doppler on there, you realize that the E over E prime is greater than 15, and that's how you know that you went from just a normalization to pseudo-normalization, or a normal diastolic function to pseudo-normalization, is that E over E prime being, if you saw back here on impaired relaxation, it was less than 15. It bumped to higher than 15 on your pseudo-normalization, And then finally, with restrictive LV filling, your EA ratio is crazy. It's like greater than 2. Your E is really, really high because the heart is so restrictive that that's the only thing it can do is that you get this crazy E wave greater than 2 over your A wave. And on the tissue Doppler, again, you've got E over E prime greater than 15. So putting it all together, if you wanted to do a screenshot or do a laminated card, this would be the thing to do. If you wanted to do all this tissue Doppler stuff, again, you could stop right at that sort of impaired relaxation if you wanted to and do that for a few months and then just keep peeling back layers of the onion until you want to get to all this diastolic Rosetta Stone stuff. And so, yes?
A prime, I don't see it used for anything. Do you compare it to anything?
You're right. A prime kind of, if you go through all of these, if you look right here on impaired relaxation, it just generally said A prime greater than E prime. But you're right. You're not using the value of A prime for any particular thing. That is true. Any other questions about this? Okay, cool. All right. Here's another little fun factoid thing you can do with ultrasound of the heart. Subxiphoid view. This is the view all the surgeons kind of first learn when they do the FAST exam, right? Put it below the liver. Patient takes a deep breath. With the liver, you can see the heart really well in the subxiphoid or subcostal view. And when you look at the, normally you wouldn't look at valvular flow here because you're too perpendicular, right? But if you had a newborn come in who wasn't oxygenating well and looked really cyanotic, you start worrying about an atrial septal defect. And you can see that little PFO in here where the blood is now, here's your probe, it's actually now it's moving parallel where it's not supposed to between this, in this patent foraminal valley. And so that's one way to use color flow, in this case power flow, along the atria in a newborn patient worried about PFO and who isn't looking so good. Does that make sense? Now it's parallel. You wouldn't normally expect flow there, but that's how you pick these up in that view, the subcostal view.
Would they see it without power flow? Or would power flow be required?
They could just see the defect there on grayscale alone. Absolutely, yeah. Sometimes you could see that.
Just on regular color as opposed to.
Oh yeah, you could. Well, I like power because it's a little more sensitive, but you could color flow would probably work. You'd probably see the change in color. They're going up and down, blue and red. Yeah, you could probably do that. Power flow is more sensitive. It's got a higher sensitivity because it's not worried about directional flow. It's just trying to find flow, and so it's a little bit more sensitive. Okay, we're going to talk about tamponade briefly. Tamponade. This is one of my favorite ultrasound videos that I have. So what view of the heart is this? Subxiphoid, good. So liver, this is the pericardium coming around here, right? What chamber is that? LV. You know something funny about that LV? The walls are kissing. Call it kissing papillary muscles, kissing paps. That's abnormal. The LV is empty. You should never see that. That's a hyperdynamic or an empty LV. Something's blocking the flow of blood into the LV. In this case, it's because of pericardial tamponade. There's a clot sitting here in the pericardium. This patient had no pulse. Are they dead? So this was a blunt traumatic patient who came in, no pulses, CPR is being done. We paused CPR in the middle of the code. We're doing the FAST exam while everybody's, getting all the resuscitation stuff going. And they say, yeah, there's no pulse. And my surgeon's here, no pulse, blunt traumatic full arrest, no pulse. What's the survivability?
Very low. Very
low, right? It's like 0 to 1%. It's like, oh yeah, no pulse, blunt traumatic full arrest. Well, that's how we used to be. But there's something called PCM, pulseless cardiac motion. And that's what we're looking at right here. Pulseless cardiac motion is actually the heart's moving. There's just not enough blood pressure to feel a pulse. Some of these patients with larger body habitus, you're wearing gloves, and there's, it's like so hard to tell. It's like such a barbaric way of testing to see if somebody's dead or not is by feeling for a carotid. It's almost comical how often the more you use ultrasound in the middle of a code, the more you'll see actually like potential causes of their arrest. And it's actually, I think it's an ATLS now is doing ultrasound for this very reason, to check for tamponade. So this is tamponade, and there's two ways to know. One is a quantitative way, one is a qualitative way though, and that's what I want to show you here. This is the this is the right atrium and the right ventricle. do you see how they're kind of doing this dance back and forth? There's this kind of thing going back and forth, almost like a teeter-totter. And it got me thinking about, that's playing pretty well, yeah. So you can actually see sort of like this, between the RA and the RV. See, this is the free wall. This is the RA free wall and the RV free wall there. And with tamponade, it's diastolic collapse of the RV. But that's kind of hard to tell which is diastole, which isn't. But if you look, you'll see that dancing back and forth, and to me that means there's tamponade there. The question is, you know, what's tamponade and what's just a pericardial effusion? You're going back and forth on this all the time. And maybe this is a little bit of, you're starting to see a little bit of just that punching in there of that RA, and that, you know, that's one of the things I would watch this patient very, very closely. Even though there's not a large effusion here, I would be very cautious with this patient because of so much tenting there of their RA, and you know, you could tell it's not really affecting the RV so much right here, but it's definitely early in the sense that that RA is being affected, and who knows how much longer it'd be until this patient's in full-blown, you know, John Travolta tamponade, like this patient here, where you're just seeing it just kind of going back and forth between the RA and the RV. You get this sort of morphological picture there. But there's another way to do this quantitatively, which is using pulse wave Doppler. Now, as you breathe in and out, the pressures in your heart are changing, and you know, I always forget which is which. It doesn't really matter for what we're about to do, but I guess with expiration you have increased mitral inflow, and with inspiration you have increased tricuspid valve inflow. But again, it's all that matters is the delta, what we're about to see here. So when you have tamponade, okay, and you're breathing in and out during pericardial tamponade, all these patients are short of breath, right? You're breathing in and out, you're having a change in that velocity across that mitral valve, the mitral inflow velocity. Just like we did the E and the A stuff with that diastology, you're going to do the same thing here with tamponade, okay? Because if you have a huge swing in velocity across that mitral valve, like more than 25%, that's what tamponade is. I think they call that pulsus paradoxus. But so what you do is you do the pulse wave Doppler across the mitral valve inflow leaflets in the apical four-chamber view, just like we did for the diastolic stuff. And then you slow down the sweep speed. Okay, that's really important. Because the sweep speed, you know what that is? That's the pulse wave Doppler sweep speed. I slow that all the way down. So we get a whole bunch of beats on one sweep, okay? And then I look for the V peak max and the V peak min. The V peak velocity peak max, and subtract that from the V peak min. And if it's more than 25%, then I worry that there's pulsus paradoxus or pericardial tamponade. Okay, are you with me? So here is a patient. You can even see their effusion at the top of the screen over there. Okay, the little pericardial effusion, apical four-chamber view, pulse wave Doppler across the mitral valve leaflets. Patient's breathing in and out. Slow down that sweep speed, and then V peak max minus V peak min. It was 180 minus 120 divided by 180 is 33%. This patient has pericardial tamponade. So yeah, you could totally do this in the subxiphoid view, or you could go to apical four-chamber and pull up a value. And that might make you feel more confident when you're going into battle for a pericardiocentesis. This is a patient whose V peak max, V peak min was only 12.5%. Okay? Less than 25%. Any questions about that? Do you guys know who the EMC is? The EMC is awesome. Here, I'll let the EMC explain the tamponade thing to you way better than I could.
The EMC, chapter 1. Follow easy diagnosis, tamponade doesn't take an act of God. Just a few easy steps makes you the man for the job. Step 1, peristernal bond, find the effusion. Step 2, the IBC, when they breathe, what's it doing? If the fluid's backing up, won't be flattening or relaxing, the walls remain static. Even the fatness in the hepatic vein can be dramatic. Step 3, the RV free wall. You should be asking, is it actually collapsing when it should be expanded? And diastole, the RV wall is relaxing and the fluid bows it in when tamponade is happening. So get your M mode in your peristernal bond. Remember this technique and you'll never get it wrong. In the diastolic phase, the mitral valve opens. Front leaflet is a septum and systole it closes. So get your M mode and where does that line go? Over the leaflet and the RV. You gotta hit them both. And if the wall's bowing in when the valve is opening, you can tell your consultant tamponade is closing in or release a strong chance. So get your needle ready, and if you haven't shit your pants, you can move to step 4, but that's a little more advanced. Could be a bit of obnoxious to know the physiology and be aware of the process. So remove your textbooks from under those old pairs of socks and unfolded pairs of boxes and open up to the page, the pulses, paradoxes, and don't lose your pulses. Come on now, you got this. Let's all go through it. Your oxygen in your ventricles and pericardial fluid. It creates a fixed space, and when the heart can't expand, the septum is displaced. And which way that it moves, right or left, is just based on which phase of respiration that you happen to be in. Breathing in and out, thou salve, and a habit of BM. So what happens when you breathe in? Negative pressure sucks blood into the right, then out goes the septum to the left, and down goes your left side of feeling is systemic outflow, then out goes your breath. Upon expiration, the pressure is changing, left side of feeling increases. So why this explanation? Well, because it's making all your echo skills better. So let's review again, and we'll go through it together. Breathe in, blood in the right pushes the septum to the left. Breathe out, LV expands, and you take another breath. Breathe in, LV shrinks, and it fills up less. Breathe out, it fills more, and you can put this to the test, because you're an echocardiographer / doctor armed with an 8.4 and a spectral Doppler. Gate over the mitral valve, use this as your window, and if you detect 30% drops in your inflow upon inspiration, well, if you follow this, should give you inspiration. Go and call your cardiologist. Just some information to polish up your knowledge with. If in this situation, you can straight up demolish it, because all of this is just to remind you of the facts. It's the end of chapter 1, and after, more to come. To memorize this track, just rewind it back. This Dr. Hahn signing off, EMC, that's a wrap.
Pretty good, isn't he? Pretty good. So he's a resident at Highland. He's in his 4th year now up at Highland. I know he's looking to go back east for a job. But yeah, no, he's we're doing UltraFest at UCI. UltraFest is a big ultrasound festival we do once a year at UCI. We're doing it February 6th, and he's going to come down and perform. And Mike Mallon from the podcast is going to come out and do the keynote. So you guys should, if you're around February 6th, I think it's a Saturday.
Med student.
It's a big medical student, thing, but it's just we have a bunch of different rooms. We get about 300 students coming in and going all the different stations and stuff. It's pretty fun. It's our 5th one. I'm going to shift gears there a little bit. I think we still have a little more time here. I'm going to shift gears and I'm going to talk to you. Just going to go through a couple of articles I think are interesting that sort of recently came out that I've been doing in my journal club and stuff, and get to see what if you guys have some thoughts about this. One of the major impediments to doing point-of-care ultrasound, I hear all the time, is this concern about lawsuits and about, I'm going to do an ultrasound, I'm going to miss something, I'm going to, cause a lawsuit, and I've sort of been aware of some of the stuff that's out there, and Dr. Blivus is probably the person that gets consulted the most out of all of us in ultrasound to be an expert on cases and stuff like that. So he's like, most of the time these cases are not because the doctor used ultrasound and made a wrong diagnosis. In fact, he couldn't find any of those in literature. The cases surround sometimes the failure to do an ultrasound, particularly when it comes to vascular access. And so that's just something to think about. Like if you're trained in ultrasound and then you don't use it, and the patient has a negative outcome, that you're more likely to get in trouble in that vein than if you use it and you make the wrong decision based on its erroneous results. So what they did was this lawsuit thing. They did a retrospective review of all the cases from 2000 to 2012 in this big law database. They include them if there was an emergency physician named in there, if the patient encounter occurred in the emergency department, and if the case hinged around the interpretation or failure to perform an ultrasound. And they did it based on the ACEP core applications, and they assessed risk that involved ultrasound that could have been performed but were deferred to radiology. So the patient's care was delayed because they sat around waiting for radiology to do the scan, and a lawsuit resulted. They included that. And so they found 5 cases. They only found 5 cases during this 4-year period, and 4 out of the 5 resulted in a patient death, and all the studies were within the scope of what we do, and there were no cases, as I mentioned, no cases of failure to interpret or a misdiagnosis made on an erroneous conclusion from ultrasound. Okay, these were the cases here. I'll just read them to you because it's kind of hard to see. Middle-aged female presents with calf pain. Ultrasound study was reported to be negative. The patient died from a fatal pulmonary embolism. That was an ultrasound performed down in radiology, and it was failure to perform a complete examination in the setting of DVT. Now I know we do, well, let me just read through these cases and I'll have a comment about that. The second one was a teenage patient with calf pain, palpitations, and presyncope. EKG and chest x-rays are normal. patient died from a PE, massive PE. The department failed to order a DVT ultrasound. And so how many of you diagnosed DVT in a teenager? I had a recent case of it, a very interesting case. This is one of those things that's kind of rare, but ultrasound kind of lowers your threshold to pick it up. So if the patient had a massive pulmonary embolism, there's a chance that they would have found clots somewhere, either in the IVC, which we do a lot for fluid assessment, breathe in, the IVC collapses, and also for a point-of-care ultrasound for DVT. Another one was a teenage boy presented after a motor vehicle collision. No abdominal imaging was performed. The kid went home. He died later that night with liver lac and hemoperitoneum. Nobody did a fast scan or any imaging for that matter. I mean, that's just probably negligence. But, an ultrasound, a fast scan, a guy who died from hemoperitoneum probably would have been abnormal about it. Another one was adult female with abdominal pain, right upper quadrant. Was scheduled the next day. It showed cholecystitis, and there was a delay. The patient suffered complications from the right upper quadrant, delayed from that diagnosis, and that's again, it was a delay to do the imaging, which we could easily perform ourselves. And then an adolescent male, of the teenager with the DVT. And so it's just like the people you don't really think about it in. The nice thing about ultrasound here is that it lowers our threshold to pick it up. But DVT is kind of funny, and while I really like the positive predictive value of DVT, when I see it, it's like awesome, and I made the diagnosis. The negative predictive value for 2-point DVT, I think really needs to be put in the context of a lot of your pretest probability or suspicion. If my pretest probability is high, Wells criteria is high, I do my 2-point point-of-care ultrasound, I don't see a DVT, I'm calling radiology for those studies. It's one of the few times I will do a radiology ultrasound. If my clinical suspicion does not coincide with my bedside ultrasound. Okay, does that make sense? On the rule out. But if I'm like, oh, this patient's very low likelihood of a DVT, I can find other reasons while I'm looking for DVT. Oh, I find cellulitis, and I find a lymph node. That's why, and a large lymph node. That's why their leg is swollen. Then I'm done. I don't get one from radiology. It doesn't make sense to me at that point because my whole gestalt has changed. I found a reason for them to have a swollen leg. And so, but just keep that in mind. DVT is one of those funny things. Even though there weren't any lawsuits that had to do with a point-of-care ultrasound for DVT, I think that it's just still an area that if my clinical suspicion doesn't follow what my ultrasound shows, I usually get a radiologist study. Or I take the time and I march all the way through the superficial femoral canal and I go down the tibial veins if I'm that curious. And I happen to have the time at that moment for some reason, because that's an extra probably 10 minutes to do that, which is a long time to spend doing anything in the emergency department. Another study I really liked came out. There's a couple of them here that get on this topic about a saline flush test. After you put a central line in, confirm that it's in the right location by squirting some saline contrast. Basically, you take, have you ever done this before where you take normal saline, or somewhat like a nurse like injecting a medication or something, and you have to look at the heart, and then you see like these things in the heart, like these little dots come in the heart, like swirling around, So you don't even have to agitate the saline. It doesn't have to be a 3-way stopcock. It could just be saline that gets injected peripherally, and just look at the heart. So what they did was, any patient who had an above the diaphragm central line, they consecutively enrolled these patients that after they got the central line under ultrasound guidance, they looked at the heart, and they looked for a saline flush in the right ventricle, and they also looked for an ipsilateral pneumothorax on that patient as well, and they got all chest x-rays on all these patients. 81 patients, 13 got excluded. The mean catheter time to get the catheter under ultrasound, that includes like dragging the ultrasound to the bedside, putting all the gowns and everything on everybody in the room and sterilizing everything, 8.8 minutes. The catheter confirmation time by chest x-ray to view was 45 minutes. To get a reading at a radiology was even longer. But if you looked at the sonographic confirmation versus the radiology confirmation, there's a significant p-value, as you would expect. This was another one in the American Journal that did, quote, the bubble study, and they said, same sort of question, can we confirm these things a little bit faster ourselves rather than having to wait for radiology, and also can assess for a pneumothorax. They did a blinded chart review, and they looked at the chest x-ray timing, catheter positioning, and complications. They enrolled 50 patients, 4 got excluded. The ultrasound time was 5 minutes compared to 28 minutes to get a chest x-ray, with a mean difference of 23 minutes. When they compared the ultrasound confirmation time to chest x-ray time, the ultrasound was, If you added it out, it was 24 minutes faster. But if you looked at how long it took to get a radiology read on these patients, it was like 294 minutes later to get a radiology read. And so, you know, there were 3 misplaced lines, 2 patients with pneumos. Everything got caught on ultrasound and correctly identified and repositioned on ultrasound. So, did you have a question?
No, I mean, so are you, at your institution, are you still getting chest x-rays? You know, because a lot of these things that you're talking about, we know it, but when we call our consultants, they go, yeah. What did the chest x-ray show?
Yeah.
Yeah. What did the official echo show? So
We get chest x-rays done on 100% of our patients. We put central lines in. I'm just sort of bringing up these. One of my trauma surgeons. He's a part-time trauma surgeon at UCI, but he's mainly up at Holy Cross Hospital in Los Angeles, there in Chatsworth. And this guy Boris, he's so funny. He's like, yeah. He goes, probably 3 years now. I haven't ordered a chest x-ray, and he spends his life in the ICU, in the SICU. He's like, I do everything now by ultrasound up there at Holy Cross. Nobody seems to care, and it's fine, and I haven't had any problems. It's just because ultrasound is more accurate than a chest x-ray, certainly for pneumothorax and for line placement. I'm involved in this thing I can't talk about, but it had to do with a misread on a chest x-ray, and where ultrasound would have, this saline thing would have prevented that would have showed that line is not in the right place. And so I think it's just safer. So yeah, we kind of do it, we teach it, but every patient gets a chest x-ray, which is okay with me. It doesn't slow me down. Like I know that I'm in the emergency, I'm doing the right thing for the patient. I think this has more of an implication upstairs when they're waiting around for a chest x-ray.
Well, the other thing is placement of how deep the line is. So as all the residents here should be doing with every single line that we place, at least with me, and I'm sure with several of the ultrasound faculty, you ultrasound to use it now, to start using it now, order the chest x-ray for the hospitalist, right? That's their Christmas gift. This is our Christmas gift. But as far as how deep it is, that's somewhat helpful.
Well, this is what it looks like in a subcostal view. Regular saline.
May I have your attention, please? We have concluded our testing of the fire alarm system.
Oh, good.
Please resume normal procedures for reporting
Yeah, I was
code
gonna say,
red.
it's not like there's a fire.
May I have your attention, please? We have concluded our
I'm still
testing
waiting
of
for
the
my
fire alarm system.
emergency department
Please
to burn
resume
down.
normal
Whenever they say
procedures for reporting code red.
code red, building 1, I get so excited that we're finally going to get a new ED, and then of course they're like, code red all cleared. I'm like, really? So, but that's just regular normal saline. You can see it in the RA and the RV. That's just like, push the flush in the line. And that's what it looks like. Super easy to see. You don't need color or anything fancy. It's just like those dots come in there. You can kind of overgain the image if you want. That helps. I do that a lot with ocular stuff as well. So that's just a regular saline injection scene that tells you in the right place. And then, I want to talk to you just a quick second about dyspnea. And they took patients with, this is kind of an interesting study. They took a bunch of patients who came in with shorter breath, and 168 patients. They had 2 groups. One of them got an immediate point-of-care ultrasound of the lungs, looking for B lines, and pneumothorax and pneumonia. The other patient, they delayed the ultrasound. They made them wait for 1 hour. Okay, so they all came to the emergency, wait for 1 hour. 1 hour is not that long of a period of time, right? 1 hour is like, it just seems like it goes by like that. But in that 1 hour, they found some interesting things. 88 patients, group 1, 80 in group 2. Group 2 is the 1 hour group. Group 1 was the immediate group. The concordance between initial and final diagnoses was different in group 1 and group 2 for a significant p-value. Basically, the percentage of wrong initial diagnosis in group 1, the immediate ultrasound group, was only 5%. The percentage of wrong diagnoses in the let's wait 1 hour to do a point-of-care ultrasound of the lung in group 2 was half the time they got the diagnosis wrong. And it could have been one of those things where they were trying to throw the results. Like if I got chosen, it's like the Hawthorne effect. Be like, I don't know, maybe it's I could see them like the people who were involved in the study knew what they were doing, and maybe they kind of gamed the system a little bit, because that's just ridiculous to miss it by 50%. But bottom line is, though, I think POCUS kind of it reduced the errors and it made them more accurate. And this is, you guys know what B lines look like here. It's just an example there of these hyperechoic lines that extend to the bottom of the screen. What happens is that you get, normally in the lung you have A lines, like on all of us right now. We put a probe on our chest. You're going to see equidistant lines that come down from our pleural line. The pleural line is where the lung comes up to the chest wall, rubs back and forth. You get these equidistant horizontal lines that come down from that pleural line. Those are A lines. But now when you have fluid replace the air in those interlobular septae or in the alveoli space, now what happens is, instead of there just being this this artifact of an A line, now you get this crazy B line artifact, which is where that fluid interacts with the sound a little bit more in that little space, and it gets this comet tail that extends all the way to the bottom of the screen. So that's what pulmonary edema looks like, fluid overload, that kind of thing. And that's B lines. There's another example of a bunch of B lines in here. And you can have like one or two be normal, but if you see multiple B lines, coming to the bottom of the screen there, and with pulmonary edema, it's bilaterally, right? You put on both chests, and you're going to see these bilateral B lines to make you feel very confident to maybe turn down the fluids or even reduce the amount of fluids in the body. And then finally, I just want to talk about appendicitis briefly. This was one of my colleagues I've known since junior high. This guy, Sean Rangel. We sat next to each other in typing school. He went on to become a pediatric surgeon. He works in Boston. He did this huge, giant study looking at the trends of CT and ultrasound for appendicitis. They enrolled 52,000 patients in this crazy study, and they looked at this from 2010 to 2013. Over this 3-year period, the ultrasound went up by 46% in the use of ultrasound to diagnose pediatric appendicitis, and CT decreased by a little bit more than that, 48%. But they're also worried like maybe there's more negative appendectomies, but actually the rate of appendectomy declined during the study period from 4.7 down to 3.6, and meanwhile the percentage of perfs, repeat ED visits, did not change. So they were excited to report that even though we're using a lot more ultrasound, we're not causing more negative appendectomies or increased rates of ED utilization or anything like that. And so bottom line is, and I know you guys are like preaching to the choir here, but it took me a while to make my ultrasound techs better at appendicitis. So who does the ultrasound appendicitis? Do I do it? Yeah, I'll give it a crack. I'll spend 3, maybe 4 minutes until I don't see the appendix, and then I walk away and I order one for radiology. If I find the appendix, I record the whole thing on video, save some still images, measure it all out, show my surgeons. Surgeons take the patient directly to the operating room. Perfect, done and done. But if I don't see it, and again, I'm suspicious, I get one from radiology. Radiology groans about this. They're like, oh, really, appendicitis? But I just kept hammering them over the last 5 years with this. They're finally, like, the techs are starting to get better at it. And so you got to really hammer your techs with this, and they will get better at it. I think it's good to just order this and order this and order this until they develop those skills. Now, if they can't find the appendix, they give up or they can't find it, and I go in there and I talk to the patient. Now we're several hours into the case, and the patient's still really in a lot of pain. At that point, I'll call a surgeon. Surgeon will come either evaluate the patient, or I'll transfer the patient to a pediatric hospital where they'll be seen and evaluated. And if they go to a pediatric hospital, then there's a pediatric sonographer who does a way better job probably than my adult sonographers did. And now there's another chance for them not to get a CT scan. So I give them multiple chances not to get a CT scan along this way. Does that make sense? If I go back to the room, the patient's feeling a lot better, laughing, eating, running around the room, I send them home and tell them to come back in 12 hours, even if I can't find the appendix and the radiology can't find the appendix. And you could do stuff with the Alvarado scores and all that junk too, but that's sort of the way that's my take on it.
Isn't there some evidence to say if you can't find an appendix, that's actually a favorable sign, right? Because you're seeing nothing, no fat stranding, no fluid, nothing.
Right, because when you do have appendicitis, what's happening is, I think I have one. This is a normal appendix here. Feast your eyes on it. It's a rare finding. When you have bowel pathology, it suddenly becomes much easier to see. Same thing with small bowel obstruction. Same thing with diverticulitis. On ultrasound, those things are hard to see. So it's hard to see normal bowel in ultrasound because it's all filled with air. But when you have a portion that's filled with fluid that's all distended, that's aperistaltic, and the patient points to where the pain is, and you go to compress it doesn't compress, and there's a fecalith, there's a nice shadow there at the entrance of the appendix, then I think it's a lot easier to see these things. This is another normal appendix here, kind of stretching all the way across. Some of them are kind of long. I don't know if you can, oh yeah, it comes up pretty good.
Can you point out which?
Sorry, yeah. So this is all the appendix coming along here. And just the way I do this is the psoas muscle right here, okay? Here's iliac, down here, iliac vessels are right here, artery in the vein. And then what I do is I just compress. I take the linear probe. I use linear probe 95% of the time. Some 55% of the time I use curvilinear. Linear probe, I just have the patient bend their knees up. I give them fentanyl, and And I go in and I compress, push, and I do this graded compression technique in the transverse plane, mowing the lawn, coming over, coming down, and then I go sagittal, and I do the same thing. I do graded compression 1 centimeter apart, nice and slow. I might spend 4 minutes at the most doing this, and if I don't see the appendix, then I'm done. But my technique though is to push until I see the psoas muscle come up and hit the abdominal wall musculature, and that squishes the bowel between those two muscle bellies. And that's what we're seeing here. This is psoas, and the abdominal wall musculature is right here and also up here. And then this is the normal looking stretched out blind tubular structure, which is the appendix here. It was less than 6 millimeters in its diameter, so it was normal. This is what an abnormal appendix looks like, because you can see, you know, if you were to go, first of all, it's non-compressible. It's like a straight up non-ovoid or round structure, and it's like from here to here. This whole thing was like 1.2 centimeters when we measured it out. You can't tell from the scale, but that's the idea. And we put some flow around it, and if it lights up, it's all hyperemic around. We call that the ring of fire. This is what a fecalith looks like here. It's just basically this stone here. This is the entrance of the appendix, and there's a stone coming in. It's all zoomed in. It's kind of hard to see, but this is like a 1 centimeter appendix over there that's inflamed. This is another example here of appendicitis, and we're searching along. This is the appendix that's getting caught right here between psoas muscle down here, and then here's my abdominal wall musculature up here. I measured out, it's almost 1 centimeter from the outer wall mucosa to the outer wall mucosa there. And so, yeah, it's this part that lacks peristalsis. Okay, so any questions about appendicitis? This is not appendicitis. What is this? AAA, very good. Any questions about appendicitis before I move on? So if I have a little bit more time, I was just going to throw some cool cases at you. Is that cool? Do we have a little more?
Time as well.
Oh, good. Oh, good. Cool. Okay. Well, these are some of my favorites. Some of the cool, juicy pathology that we see during QA that we want to share with the world. This is just somebody comes in, single episode, choking episode. Thought they were choking. Turned out they syncopized from something completely different. They weren't choking. Somebody doing the Heimlich maneuver on somebody who wasn't even choking. They syncopized and they're pushing on their AAA the whole time. And you can see these things are the reason why, like Virchow and all those William Oslers that came before us, the reason why they would say the AAA is the great mimicker and will trick you, and they have all these clever quotes throughout medical history, is because of all that mural thrombus. Do you see all this? This is all clot. Here's the lumen here. The actual AAA is like from the spine all the way up here, but it's dampened. The pulsatility is dampened by all that clot. That's why you can't detect these on the physical examination. And here's another one here, another AAA. It's just a huge intraluminal thrombus going on there. You could see that. It's kind of like bouncing all around in there. You can imagine that it would be showering some distal microemboli. What's this? Yeah, dissection. So dissection's cool on ultrasound. You can see the little flap there in the aorta, and it's really obvious when you have a flap. But the problem with dissection, though, is that eventually blood gets in behind that flap, it fills in there, and then it stops flapping, and blood is, when it crashes out of solution, becomes a clot, it's echogenic. And so then you no longer see the flap. So it's hard to rule out a dissection on ultrasound, but boy, it's cool to rule one in. Kind of rare. For every 10 AAAs I see, maybe I might get lucky to find one dissection. So it's kind of a cool case there. How about this? I'll have to throw these in. Just a pretty positive fast scan, standard run-of-the-mill, positive fluid there, hepatorenal fluid, and then Morrison's path. It's just every once in a while, I just like to look at that. Just reminds us, kind of where all point-of-care ultrasound started, right? This is like from the historical documents from Galaxy Quest. This is like the historical documents up here. What's this? This is a 16-year-old patient came in with sore throat, fever to 39, lymphadenopathy, like tender lymphadenopathy, submandibular. Yeah, this is like a huge spleen. So we look at these patients with big spleen, we think before giving them antibiotics, I look at their spleen. If I see like a 22 centimeter spleen, that normally that looks like the liver. Usually, you can't see the left kidney so well because the spleen is so much smaller than the liver. But when I can see the whole left kidney beautifully transmitted by the spleen, then I start dropping calibers. And this is somebody who, if I see a big spleen like that with all the signs of, mono, then I don't give antibiotics to them. And I tell them not to engage in sports for 3 weeks. What about this? What's going on with this ultrasound image? Just throw out some organs. This patient fell off a horse. So,
Zachary, what are we looking at?
I think it's the liver, possibly.
What do you see?
On the left.
No radiologist, no.
Obviously, a very hypoechoic, possibly fluid on the left-hand side.
So this is, I agree with you.
There.
That's fluid. I agree with that statement up by itself. So it's kind of a little bit of a trick. This is actually just fluid in the stomach. And so this is one of those things that freak people out in the trauma bay in a hypotensive patient. This woman had it. She fell off a horse, she had neurogenic shock. Her blood pressure was 60, and her heart rate was 60. And, we're pumping her full of fluids, nothing. Her blood pressure is not changing. She just lost a vasomotor tone from this neurogenic shock. And we saw that fluid there. She went to the operating room for a laparotomy. Pre-op diagnosis, hemoperitoneum, post-op diagnosis, presence of gastric fluid. So it's like one of those embarrassing moments where, we had to explain everything to everybody and show them, remind our surgeons. They saw this, they got very excited. A surgeon sees black stuff on a fast exam, they start sharpening their scalpels, they get very excited about that. So just be careful on the left side of the body, the stomach's over there. And so that's what this is right here, fluid in the stomach. But you got to look at the area between the spleen and the kidney. This is dry. Every once in a while we can see it. This is a dry splenorenal area. You guys see that? This is one of those. Arun Nagdev wrote a cool article about the fluid in the stomach, the false positive fast scan sign, and had CT, had all these cool images and drawings and stuff. What do we have here?
Emily, call out. What'd you see?
The kidney looks hypoechoic. What do we call it? Hydronephrosis.
Yeah, I don't see any hydro either. So about 15% of the time you can actually see a stone inside the kidney. And this is nephrolithized. Did you see a stone right? Right. Boom. You guys see that right there with the little shadow? This little shadow came down. Wait, maybe I can hit K and it'll stop. Right there. So you can kind of make out the stone and the shadow coming all the way down to the bottom of the screen. It flashes by you like that. The nice thing is when you do this real time, you can always stop the machine, back it up, and you're not sitting in the audience getting pimped in front of your colleagues watching this ultrasound video. But
And if the resident had optimized the depth, it would be that much.
Bam, that's right. So the depth's here at 15. I would have taken that to a smaller number, so it would make that larger. What about this?
Keep calling out names.
Hydro.
Hydro.
Good. Good, hydro. And by the way, what muscle is this right here? See, you keep coming in right down here. The kidney sits on what muscle? Right there. Psoas. Yeah, I just like to always remember that, because when I look for the appendicitis, psoas is always on my mind, and then I'll start to notice. You start to notice these organs sometimes in other views, and so that's just the way that. If you have the patient flex their leg, you'll see that muscle get thicker on you there. Yeah, but that patient's got some, I don't know what degree of hydro, probably mild to moderate. There's a little bit of hydroureter too. You can see how it exits out the bottom of this. That ureter comes out the bottom there. So what's going on here? Yeah, where's hydro? This is like moderate to severe, maybe. Once you start to see the cortex. Well, so first of all, if you can still make out the fingers of the glove, that's like mild to moderate hydro. When you can still make out all the fingers. When all the fingers start to coalesce together, like this. Okay, does that make sense? It's like a bear claw. Okay. Then you go, well, that's more like moderate, severe. When you see the whole cortex get all squished up, it's just like a very thin sliver at the top of the screen, that's like really severe hydro. Is that how you guys understand it too? I mean, that's just, I kind of make it up as I go along with hydro, but if
If you can see it, it's mild. If you're like, I think it's there, it's mild, and we teach them if it's sort of like the, like big Mickey Mouse fingers, kind of like rounded, dog paw, moderate, and then severe is just the thin cortex.
Here. All right, what's this one here? Oh yeah, this one's interesting. Another kidney problem.
Assist.
What do you guys think? There's this. What is that?
Is that like it's not like an abscess?
Yeah, that's an abscess. It's all pus sitting in that superior pole of that kidney. That's a renal abscess. Renal cyst, spherical in all dimensions, anechoic jet black as you fan through it. Renal cyst, very common, kind of not that interesting. But a renal abscess, when there's actually like all this hypocoat debris sitting in there, kind of rare, always interesting, lots of fun. It's good living right there. Right? Bam, you see it up there? That's all that renal abscess coming on the top of the screen there. This patient went straight to the operating room based on that ultrasound. And this is what I'll do. I'll like compare the kidney. So you can split the screen. This is to show you, you hit dual screen or split screen. And so if you wanted to compare the kidneys, I do this a lot when I'm showing something to the patient or to the consultant. The hydro is on the left. That's what a normal kidney should look like there. And then this is just some more kidney stones here. Oh, that's right. This was a big Staghorn calculus. The whole thing was all hyperechoic, just all these shadows coming out of the kidney. In fact, sometimes you go to look for a kidney and you just see like the cortex and you see just fat shadow coming out of the kidney. You can't make out the rest of the kidney. That's what a Staghorn calculus looks like. This patient had an incarcerated umbilical hernia. And so when you can see loops of bowel like 3 millimeters from the probe, 3 millimeters from the skin line, that's what a hernia is. And so you could do that in the groin, you could do that all over the body, but this is like pretty typical what a hernia looks like. You'll just see a loop of bowel like right up against your probe there. And on physical exam, it's pretty obvious. And this is, what do you think this is? It's a cool one, isn't it? Yeah. Yeah. That's what I thought when I first saw it too. Careful, you get bitten by the ultrasound bug. Next thing you know, getting on some airplanes. What do you guys think about this?
Jacob said SBO.
He did say SBO. Good job, Jacob. Yeah, so I mean, it's obvious in the back of the room there. But, you can see the plicae circularis, the hyperperistalsis, dilated loops, anywhere, 3-4 centimeters of a loop dilation. But ultrasound is, I should have reviewed this article. I just reviewed this article. Did you guys see this? Ultrasound versus CT. And X-ray ultrasound is more accurate than CT was. One of the few times ultrasound is more accurate than CT scan, like gallstones here, small bowel obstruction. More accurate, and it shows the points where it can, the cause, the location of the obstruction. How about this? I can't remember what we're looking at here right now. Looks like it's in the neck. Where is this? Oh yeah. I'm not sure what this is. I think it's a big clot in the IJ, but I'm not positive. What does it say?
What is it?
Oh yeah, it is. Yeah, it's a big clot in the IJ. Sorry. See, when you give a presentation, I see both my slides, and you guys only see one. I see the next slide, so I always know what the answer is. But yeah, so this is the carotid down here, and this is all this IJ here, the big giant clot in there. PICC lines cause clots in IJs all the time. All right, what are we looking at here? Oh yeah. Yeah. What vessel? Popliteal, like it says on the screen. Very good. You always want to look around the whole screen. I like that. Absolutely. Yeah, you're doing a good job with these guys. So non-compressible, and I get back in that popliteal. What about this one here? This is in the patient's popliteal fossa. Really tender. They have the swollen area back there. It's non-compressible. What are we looking at here? Yeah, Baker's cyst is the outpouching of the synovium. Man, you guys do good. I can't trick them. Outpouching the synovium. It's in the differential. Anybody with a popliteal pain. And then, what about this? I wouldn't expect you to know what this is except the initials on the screen. RCC. The right common carotid. This is somebody having stroke symptoms. For fun, I looked up at their carotid artery and I just saw tons of plaque up there. That's what that is. That's just all plaque in the carotid artery on the way towards the brain. And this is why they were, sometimes when they're doing the whole workup and neurology's getting all interested and ordering all their MRIs and lash this and lash that, you just show them, big old plaques in the right common carotid, and sometimes it obviates what's going on. Just sort of an interesting finding. How about this? Anything, Jacob? What you got back there for me, buddy?
That's a Phrygian cap?
Yeah, Phrygian cap. Yeah, exactly right. Yeah, Phrygian cap. There's some, looks like there's also some stones down there in the neck as well. You can see them down towards the bottom here. Yeah, but this Phrygian cap is a fold up here in the fundus of the gallbladder. What's it called when you get a fold down the neck of the gallbladder? It's called a fold down the neck of the gallbladder. It doesn't have a fancy name. But Phrygian cap is if it's the top part, which is less common. A lot of patients have folds in the neck of the gallbladder, but when you see it on the fundus, Phrygian cap. Okay, good. How about this? So ultrasound for gallstones remains a conundrum. If you take some of my residents and my senior residents say, what's the hardest thing you do with ultrasound? They'll say that it's definitely the gallbladder is the one that gives them the run for their money still. And this is why, okay? So they come find me and they go, oh, I can't find the gallbladder. And I walk in the room and the first thing I do, and the resident tells me they can't find the gallbladder, I turn the lights on and I check for scars right away. Nothing more embarrassing than pointing out something and finding out later there is no gallbladder. And then, I did that one time. There it is. And then they're like, I got you. There's no gallbladder. Well played, resident. So now I learned that lesson one time. I turned the lights on. Patients don't know if they've had the gallbladder removed, right? They have no idea that somebody cut into their body. So, all right, no scars. What's going on here?
Wall echo shadow.
Yeah, good. This is a wall echo shadow. You guys know what you're talking about? So the sound comes in, and it hits the anterior wall of the gallbladder, and then it's a contracted gallbladder around stones, and it just goes boop, and the sound comes right back out again, and a big shadow remains. So west, wall, echo, shadow. Something smells like it's on fire.
Yeah. I think there is something.
It's the toner?
It's the whole hospital. They're doing work on the dogs.
Oh,
really? Oh, they are. Oh, they're.
Your lecture's on fire.
Right. What are we looking at here? Someone's so bored my lectures are actually lighting the building on fire so they get out. That's probably more.
Just expert level resident.
Cabin biles and a portal vein.
Yeah, just a giant CBD, right? Look at that. So that CBD just rides on top of the portal vein. And just as a matter of sort of fun, I told you that red is flow towards the probe, blue is flow away from the probe. We're running perpendicular to that portal vein. You see how it's blue over here and red over here? That's because that's that cosine of 90 right where it switches from red to blue. And so that's why you see that physics-wise. But yeah, so just a big old plump CBD there, which it's one of those things I just love to see. You can see the gallbladder. She's kind of coming in right here for a minute, kind of winking at us, like, hey, I'm over here. Pay attention to me. And we're not interested at all because we see a giant CBD, which is kind of rare to see a big CBD, right? Don't see that too often. How about this? This is also somewhat rare. Yeah, this is just straight up cholecystitis. It's very edematous up here. This is all edema in the anterior wall of this gallbladder. We can see the stones down here. And so a gallbladder wall should be, how thick should the wall be? Like very not thick, right? Like 3 millimeters, 4 millimeters. This is like almost a centimeter thick over there in that wall. And so this is acute cholecystitis. This is a diagnosis you can make very easily. Slap the probe on, you know exactly where the patient's going. He explains their 22,000 white count. You're hanging antibiotics, and you put the whole thing together in less than 5 minutes. Emphysematous cholecystitis would be air somewhere, and air in the wall of the gallbladder causes the sound to get scattered everywhere. You might even see comet tails, but fluid looks like this hypoechoic stuff up there. What's this one here? Oh yes, now I know why I did this one. we're looking at the gallbladder here, and we see next to it, what's the structure next to it here? What is all this? Maybe I can freeze it. Yeah. So notice this. This has a hypoechoic outer wall. You see that there? Hypoechoic outer wall. That's a loop of bowel. This is the second portion of the duodenum, D2, right next to the gallbladder. Causes all kinds of drama with the gallbladder because there's air usually in it. That happens to be filled with fluid. The patient just drank a glass of water or something. And now we're seeing a fluid-filled D2 next to the gallbladder. And so if there's air there, though, sometimes you can't even find the gallbladder because the duodenum is causing all the shadowing out of the gallbladder. And so when that happens, what do you do if the patient has got a bunch of air in their duodenum and you're trying to see the gallbladder? You can roll the patient on the left-hand side. You can tell them roll them into the car model position if you'd like, and that kind of gets them over on their side. I tell them, roll on your side like you're going to sleep on your side. It's not just like but like get all the way over so you're facing that direction. That gets that D2 to fall out of the way so you can see the gallbladder easier. What do you think is going on this slide here? Yeah, those are gallbladder polyps, exactly. Yeah, it's kind of cool to see those little dingleberries hanging off of the gallbladder there. Gallbladder dingleberries. How about this one? Sludge. Meniscus. Sludge layers out like that, a nice clean meniscus. Because sometimes when I see sludge, I get a little nervous about cholangio. Because if it's like, irregular based sludge, it's like, I want to call sludge, but wait a minute. Because cholangio can kind of look like that because it's less echogenic. It's like hypoechoic. And it looks like sludge sometimes. But as long as sludge layers out nicely like that, like a nice, smooth isoechoic meniscus, then I'm happy. How about this one here? Good. Hey, Dr. Fox, I can't find the gallbladder. I go to the bedside, turn the lights on, no scars, turn the lights off. I look at this gallbladder over here. That gallbladder is full of sludge, all the way to the top with sludge. That's why it's hard to find. There is a stone down in the neck as well. But that's your classic sludgy gallbladder that's sometimes even difficult to pick out of the liver itself because it looks so isoechoic with the liver. See how that can happen? All right, we're doing a procedure. Anybody know what we're doing? Yes, PTA. So we have the endocavitary probe. I don't call it a transvaginal probe around the 12-year-old male that I'm doing this on. Endocavitary probe. I have a sheath on it, not a condom. And I put it in the back of the throat, numb the throat up, and I can see the needle going into the abscess and draining it under ultrasound guidance. So guided procedures when you're using the long axis like that is nice because you see both the tip and the shaft of the needle at the same time. And I think that's better than being out of plane and just seeing the tip or the shaft. But when I teach novices, though, it's really hard to get to do any procedure where you've got the needle and the sound and the vessel all together in like the same longitudinal plane. It's easier to have them be out of plane with the probe initially, but eventually I think we all have to migrate into this longitudinal in-plane technique. What are we looking at here? Anybody know? Something very hyperechoic. It's an endocavitary probe. It's the same thing. This is a patient with the probe is in the throat, and this is pharyngitis. This is like an acutely inflamed lymph node. It's like a lymph node in the back of the throat that's really like a lot of lymphadenopathy in the back of the throat. And that's what this looks like on ultrasound. It's very hyperemic. That's not an abscess. Don't stick a needle in that. Okay? That's just a pharyngeal lymph node. We're on the leg. What's this? Yeah, you guys know this stuff. This is all cobblestone cellulitis. The reason the cobblestones is because there's edema that's getting there for the cellulitis. So that's what that anechoic fluid is between those different fatty islands. And those islands get hyperechoic from the cellulitic component. All the cells that are going there with that leukocytic reaction trying to fight the infection, the tissue gets more dense. Anything that's more dense is going to be more hyperechoic. Because one of the questions I get asked on rounds is, upstairs in the hospital, is, hey, how do I know if this is edema or cellulitis? Because they both look almost identical on ultrasound. Because on ultrasound, with edema, just straight up peripheral edema, you'll see these little islands everywhere. It looks like cobblestones. The difference is that when it's infected, when it's cellulitis, those islands are denser from all that leukocytic infiltration, and so things that are denser are more hyperechoic. That's how I know we're looking at cellulitis. What's this?
Swirl sign?
Yeah, swirl sign for the abscess. Yeah, it's like a volcano ready to go. So an abscess you should see swirling debris moving around when you compress the tissue. Yep, very good. These are some inguinal lymph nodes. We see them there. Hyperechoic. I should say hyperechoic. If you put flow on these lymph nodes, they'll light up actually. You put the power flow on, you turn the sensitivity way down, you turn the pulse repetition frequency really low, and so it's not talking so much, it's listening more, and it makes it more sensitive. Because the better you are of a listener, the more sensitive you are. So you make the machine listen more by turning down the amount it's talking. You turn down the pulse repetition frequency using pulse wave Doppler, and you'll see those little lymph nodes light up with hyperemic, nice flow pattern there. Oh yeah, this is a patient who came in. It was a trauma patient, not wearing a seatbelt, hit their steering wheel, and x-rays were negative for sternal fracture. But on ultrasound, we found out why they're having so much chest pain. You can see that little step off, right? You see it right in the center of the screen? That's what it's.
Can you point it out?
Yep. Yep, I will. It's right here. Now, it's important to differentiate a sternal fracture from the manubrium. So I always start right on the manubrium because it looks kind of similar. It's the joint of the sternum. You start up in the manubrium, and you'll see the two bones come together, and then you just slide down. You kind of fan side to side as you're going down the sternum whenever somebody has blunt trauma to their sternum. You'll find you'll start to see the sternal fractures. X-ray misses them all the time. They get picked up on CT. This is another fracture step off we can see right here. This was a patient's zygoma. So I took the probe, I just put it right along their zygoma right here, and I saw a tough bone to break, right? Somebody really has to get you with an object here, but you can pick it up right there at the bedside if you want. You see that zygomal fracture there. Just an example of a big step off with fractures. You see the bone, the other bone, and really easy to see these things. This is another example of just these fractures. That's a rib fracture. I diagnosed my own rib fracture actually. One of my colleagues last summer at our retreat was, we were having fun and intoxicated, and he came over to me and gave me a big hug and broke my rib. I knew it immediately. I felt it pop right here anteriorly. And Chakrabarthi, I don't know if you guys know him or not. He was the program director for a while. Gave me a big hug, and sometimes love hurts. It does. And I said, dude, I think you just broke my rib. He's like, rrr. And so the next day I looked at it with ultrasound, and it was awesome. It looked exactly like this. It was a little step off there with a hematoma around it. It took about 6 weeks to heal. This is a broken arm that had some. We did ultrasound reduction until we got the bone ends back together. So yeah, you can put these bone ends back together under ultrasound guidance. Our orthopedic surgeons are all doing this now. We started showing them how to do it. Now they're all asking forward doing it. So it's kind of like poor man's fluoro, if you will. You can kind of bring the bones, and it takes a bunch of people though. You need like someone to do the reduction. You need someone to hold the probe on the machine, and someone to like deal with the patient's pain and stuff. And so, but you can do this. You can do these ultrasound guided reductions. This is a shoulder going in and out here. So you can see this is somebody who can actively dislocate their shoulder like Mel Gibson did in that movie Lethal Weapon. And so you can actually see, so this is the glenoid right here, and then this is the shoulder. This is the humerus, the head of the humerus over here, and anteriorly dislocated. So right now it's dislocated anteriorly, and then now it's more posterior. So the sound, to orient you, the sound was on the back of the shoulder. So I've got the sound like coming from back here, linear probe, and you just line up. You go glenoid, humerus. And if the humerus is anterior to the glenoid, which they are in 90-something% of shoulder dislocations, you can confirm it's out. Now, normally this is a very clinical diagnosis to make. You don't need ultrasound, but once in a while you can come across somebody who's got like really, large anatomy, and it's kind of hard to see what's going on. I think this is very helpful. You can also use the curvilinear probe on patients where they have a lot of, soft tissue between their bones and the skin line. And so we did a study looking at this. We took college students and put them in the room, taught them how to do ultrasound for shoulder dislocation. We put them in the room, and we said, have at it. This is how you do it. And they were 100% accurate. They could pick out the dislocations. They had 20 positives and like 130 true negatives, and so they didn't miss anything. These were not doctors, college students. This is study took forever to do, by the way. It was a pain in the ass. But yeah, just a wood splinter. Sometimes when it's kind of hard to see a foreign object in the tissue, but if you look at the normal tissue lines, like here's the tissue planes, right? They're kind of going like this across the screen. Do you see that? This interrupts that normal tissue plane. And so that's how you find a foreign object. It interrupts the normal, like, applanation of the muscle fibers in this case. Here's an example here of somebody who has, what is going on here? Ah, yes, tendinitis, right? Yes, inflamed flexor tendons. You put that on the wrist and you'll see these. Not only are they really hyperechoic, I thought it was what we have come up here in the next slide, it's almost similar to it, but there's also all this edema surrounding. See all this edema surrounding these flexor tendons here? That's not supposed to be there. So if you look at your own tendons right now, you'll see the tendons are pretty hyperechoic, but they don't look that bright, and they don't have all this edema surrounding them. And so that's how you can find all kinds of flexor tendonitis stuff. This patient has a pneumothorax. Very good. Lack of lung sliding. Okay. This is a pleural effusion. Yep, you can see the little salamander tail there. That's the lung, the atelectatic portion of the lung. Okay. What's this? We had 2 lung things in a row. Think about the lung. So that's pneumonia. That's a lobar consolidation, what we call hepatitization of the lung. In fact, there's some fluid bronchograms right here. That's what this air fluid is right here. These hyperechoic punctate dots. Right. We see it surrounding the bronchiole, right? Right in here, this region right in here. See that right there? That's what that is right there, all those dots there. In that, that's all lung that's just got a really good lobar pneumonia. What's this? Yeah, it's just some ascites. I think loculated ascites, just lots of loculations. And so you can you drain most of this, but you might end up spending a lot of time trying to guide into all those loculations and have the IR take care of that. But if the patient's really hurting, you could do it. We're almost done here, guys. This is the Foley balloon catheter right here. It's stuck in the up position. We can't get it out, and the patient's threatening to yank the Foley out themselves. And it's tempting to sort of walk away, let nature take its course, but instead we go back in the room and we guide a needle down to the balloon. And if you can imagine just taking like an 18-gauge needle and then just getting the balloon to pop, there's a way to do that. And the urologists hate this because they have to go in and get all those pieces out using cystoscopy. But yeah, I always tell the patients, you don't want to pull that out if you ever want to cough with confidence ever again in the future. Yeah, just right into the bladder.
I've actually seen when stuck in like in the distal urethra. I've actually seen it go perineal, like if, you know.
Yeah.
That's a urology.
Yeah, that would be fun, wouldn't it? This is just the in-plane technique showing you what it looks like when a catheter is going over a guide wire, confirming that you're in the right location. I just like that, again, that in-plane technique. This is a peripheral line where the nurses were doing. This is I believe this is the out-of-plane technique. We're trying to get into the femoral vein here. Notice how sort of medial lateral the femoral vein can be here. Out-of-plane, it's hard to know where your needle tip is. You can see the tenting there, but you're out-of-plane. It's hard to know if you back-walled or not. Whereas in-plane, you get a lot better. You just get a lot better visualization of the needle. And this is a foreign body removal. We've got the forceps open right here in plane. We just I don't know if you can see there or not. We just grabbed a foreign body with those forceps. So IV drug user left a needle in by accident. This is a knee effusion here, and we're just looking at all this debris inside this knee effusion, and we can take a needle in that long axis, easily get it into this knee effusion and drain it out. Looks like it's got a hemorrhagic component to it with those hypoechoic low-lying echoes throughout that whole knee effusion there. Yeah, this is that same patient, or maybe a different patient, I don't know. We're doing a knee arthrocentesis here. We're getting the needle in and the long axis technique into that knee effusion. draining out that knee, doing a knee aspiration. This is another example of doing a procedure. This is paracentesis, and we're trying to do in the in-plane technique. We're using the large footprint C60 probe here. We're advancing the needle. This is a loop of bowel down here. We're trying not to get into the bowel. It's kind of fun to watch this. But we can guide it, like over the bowel. This patient's had a whole bunch of paracentesis, so the needle is kind of stuck against that peritoneal wall there. But just watching, sometimes in patients who get these procedures a lot, it's kind of safer to watch it go in under ultrasound guidance. This is an example here of a nerve block. You can see the medial nerve is right here. We've got the needle in the in-plane technique coming in. We're injecting some anesthetic around this part of the nerve over here. What I would do next is I would withdraw that needle and then guide it underneath this nerve and bathe around the entire nerve, anterior to it, posterior to it, and I get all the way around that sucker. And I think there's a bunch of people really good at this. Arun Nagdev, I think, is our West Coast sort of expert who I learned a lot of this stuff from. He's really getting a lot of great slides on this technique, but he basically taught me, you want to get all the way around that nerve to have the best chance at getting a good outcome. What do you think this is? Yeah, it's testicles. You can see how hyperemic both the epididymis is here. So this is the epididymal head here, and this is the epididymal tail down here. I kind of got two views here. This is all the testicle here. It's actually somewhat hyperemic as well. And with power flow Doppler, I like to use power flow on low flow states like the gonads, like I said earlier. And you can see this is just epididymo-orchitis on this patient. He also has an epididymal cyst. That's what this anechoic area is right here. It's kind of confusing at first what that was, but this is a good example of that. This patient has a penile fracture. That's what I thought we were looking at when we saw those tendons, actually, because it kind of looked like that to me for a second. So this is just what a normal penis looks like over here. And then this is what it looks like when you've got a penile fracture. And you could see this I forgot all the names of all these layers now, but but there's all this fluid here surrounding. This is the skin down here, okay? This is the skin down here, and this is all this fluid that leaked out of one of those corpus spongiosum areas that fractured. So we get that leaking of that fluid all the way onto that space. I was going to end that lecture earlier, but I wanted to get to this because I think it's so interesting and somewhat funny. Yeah, right? Now I'm glad we waited through all that other stuff to get to really why we're here today to.
Is there a long penis view? It's a short.
Yeah, that was put on there by someone being funny, obviously.
Is there a movie video that goes with this as well, or
yeah, the EMC is going to come along and lecture now to us about penile fractures. Actually, that would be funny if you did that. This is somebody with this splint. So I didn't realize it was going to be PG-13 today. Diagnosis. Tricuspid regurg, very good, yep, very good. And just another example here of a nice pericardial effusion. See, we're doing the apical four-chamber view, but it's almost like somebody has a punching bag and they're punching that right atrium right up in there like that. I like that. I like to think of it that way. But it's also this kind of dancing free-wall-the RV. You can see my fellow calls this the magic carpet ride. But that's the idea. More MR, I think we're coming to an end here. Oh, what's this diagnosis? PE. Do you guys see that? So this is the RV over here. It's huge. There's a little moderator band kind of poking in right there. That's how I know that's definitely the RV. LV is empty, obstructive process in the heart. Massive PE. RV strain. You ever give thrombolytics to PE before? Anybody? Yeah. It's kind of scary.
Several times here.
Is that right? Yeah, it's one of those kind of scary maneuvers, but. And what's this diagnosis? What view of the heart is that? Peristernal long, yeah. What do we have?
Is that an emboli or a thrombus on the valve?
Yeah, it's a big veggie on that valve there, on that posterior leaflet of that mitral valve. There's a big vegetation there. Just happened to, we're doing rounds. Yeah, I do rounds to hospitalists. That's awesome to do. Sounds kind of weird, but it's awesome. You go up there, and they love it. You just go around bed to bed. Every patient's admitted for some reason, pneumonia, all these cool diagnoses up there, and you'll find stuff. The strokes do their carotids. This is just another, I think we already saw that one, sorry. Oh yeah, and I think we're going to end on these eyes. So just to reiterate, when someone comes with flashes and floaters, it could be that they're having a retinal detachment. The ophthalmologist, sort of poo-poo some of that sometimes. Oh, it's just flash and floaters. I'll see my clinic next week, right? But I always look at their eye. What is this? So if you overgain the machine, you can see those low-level echoes there being overgained by the machine. You overgain it, and as the patient does the kinetic exam, which is look left, look right, I tell the patient look left, look right, look left, and you'll see this like clothes in a dryer. That's what a vitreous hemorrhage look like, clothes in a dryer, rolling around back there. But they layer out when it stops, and that's how it appears. And a retinal detachment, on the other hand, is like an actual membrane that pulls away from the back of the eye that's tethered at the optic nerve sheath. So detachment has to be nailed down where the optic nerve sheath is. So if that's your optic nerve sheath right here, this retina is tethered down back there. It's also tethered out here at the ora serrata, along the choroid out here as well. And then here's just another example of retinal detachment coming off there. The macula of the eye is located lateral to the optic nerve sheath. So if it's still tethered lateral, like the lateral canthus, that direction of the optic nerve sheath, if it's still attached there, that's a MAC-on detachment. If it's no longer attached at the macula, obviously lateral to that optic nerve sheath, then it's a MAC-off detachment. And so, yeah, we went through, believe it or not, we saw all these examples here today. We also learned a little bit about diastology and the RV stuff, TAPSE, right? Talked about that. Talked about the apical four chamber quite a bit. We talked about pulse wave Doppler versus tissue Doppler. Yeah, that's kind of and then we saw a bunch of fun cases. So that's kind of like my best stuff, you guys. You guys got to see it today. That's as good as I get here. So I just want to say thanks a lot for having me out here. And last night was a great dinner we had. And once again, it was great to meet you guys. And yeah, if you have any questions, I'm more than happy to take those now.
Great job.
Awesome.
Thank you.